Good afternoon. Welcome, everyone, to our webinar today, Does the Self-Directed Funding Model Work in Mental Health? We're very pleased to have you joining us today for this webinar. As I mentioned, my name is Carla Thorpe. I'm the Director of Prevention and Promotion Initiatives with the Mental Health Commission of Canada, and it's our pleasure to be hosting the webinar today. Just before we get started, I'm going to go through just a few short housekeeping items. We are hoping to have a fairly interactive session here today, so we'd encourage you to send in any questions or comments, and we'll have some time for discussion at the end of the webinar, as well as we'll pause for a couple questions midway through as well. So I'd ask you, if you haven't already located the chat feature, which is what you're going to use to send us your questions, because we have muted all of your telephone lines. It's located on the upper right-hand corner of your screen. It looks like a little conversation bubble, and underneath it says the word chat. So if it's not available to you, just click on that button, and a panel should show up for you in the bottom right-hand corner of your screen. So that allows you to send questions into us. We would ask that you send any questions or comments that you have to all panelists. So again, you can click on the little drop-down arrow, and all panelists is one of the options that you can select for sending us your questions. Our webinar today is also being recorded, and I know we do have a lot of interest, including a lot of international interest, in accessing the recorded archives for the webinar. So that will be posted on the Mental Health Commission's website in about 2 weeks' time. We'll also be posting a copy of the slides from today's presentation in both English and in French. So if you're looking to access the slide deck, that again will be available on our website in about 2 weeks' time. And again, because we have a large number of participants that are joining us today for the webinar, we have muted all of your telephone lines upon entry just to eliminate any background noise. So this webinar that we're hosting is part of our webinar series on recovery-oriented practice. So as many of you know, the guidelines for recovery-oriented practice were released by the Mental Health Commission in June 2015. And since about January 2016, we've been conducting these webinars on a monthly basis that first of all started exploring sort of an introduction to recovery-oriented practice, and then we had subsequent webinars that focused on each of the individual dimensions of recovery-oriented practice. So all of those webinars are archived and available on the Mental Health Commission website if you did miss any of those. After we went through all of the individual dimensions, we've been doing sort of the monthly webinars on different special topics that participants have expressed some interest in. So it's certainly very important for us to get some feedback from you today on other topics that you'd like to see covered in the upcoming series. So at the end of the webinar today, there is a post-webinar evaluation. So as soon as you close out the window at the end of the session, it's a very short sort of 5-question survey and an opportunity for you to add some comments. So we'd really encourage you to provide us with your feedback on some topics you'd be interested in the future. So I'm very pleased to introduce our speakers for today's webinar. We have Dr. Bevan Croft and Dr. Kevin Mahoney, who are going to speak to us today about self-directed care and how it's been applied within the United States. So Bevan is a research associate. She is with the Human Services Research Institute. She conducts research there in a number of different areas, but including self-direction and self-determination, employment supports, peer-provided services, and a number of other areas. She's also the project director for the evaluation component of a multi-state demonstration and evaluation initiative of self-direction and behavioral health. She holds a doctorate in social policy from the Heller School of Social Policy and Management at Brandeis University, and I understand that she also has several master's degrees as well. Joining Bevan today is Dr. Kevin Mahoney. He serves as founding director of the National Resource Center for Participant-Directed Services at Boston College. He's also the principal investigator of the demonstration and evaluation of self-direction and behavioral health. He's very well known for his research on participant direction of home and community-based services and supports for people with disabilities, as well as the financing of long-term care. We had a pleasure of meeting Bevan when we were in Australia back in February for the International Initiative for Mental Health Leadership Conference, where she was attending to share some of the work that's being done in the United States. I know there was a lot of interest internationally in some of this work, and I think, you know, in different jurisdictions, individuals trying to figure out sort of how some of these principles and concepts could be applied within their local context. So certainly we're very pleased to have Bevan and Kevin with us today to sort of share some of these learnings with us in Canada and see how we might apply some of this moving forward. So I'm now going to pass it on to the two of you to get us started with the formal presentation.
Thank you, Carla. Can you hear me well?
Yes, you're loud and clear.
Okay. First, Bevan and I would want to both thank Carla and, you know, especially the Mental Health Commission of Canada for giving us this chance to talk with you, to share, you know, many of the things we're doing in the United States and in turn to learn from you and your experiences. So we are very grateful for this. Today, we are focusing on self-direction and how does it work, can it work, how can it work best in the whole area, you know, of mental health. Just to give you the quickest overview of what we hope to do today, we'll start with many of the basics of the self-direction model. And then we'll pause, you know, just to make sure, because we understand people have varied experiences with the overall model. So we'll stop, you know, for questions at that point and make sure that we have a common basis for going forward. Then we will briefly discuss the demonstration and evaluation of self-direction in mental health going on in our United States, in 6 of the states. Bevan will then present the evidence base for self-direction in mental health, and then go on and talk about some of the selected findings, you know, from the first part of this evaluation of the Florida self-directed care approach. Bevan and I, we have the advantage that our names rhyme, but to keep the presentation hopefully scintillating, we'll go back and forth as we, you know, discuss this approach and how it's worked in the United States. So as I start with the basics, and they rhyme so well with, Bevan, if you go back just for a second to the previous slide, how they are so consonant, obviously, with what you're working on in Canada. The whole idea is building on choice, recovery, and independence. And then the next slide, really, it's important to spend a little time with the principles where this is really based on recovery, people identifying their own goals for changing their lives, focusing on independence, self-sufficiency, choice, making sure it's with adequate support. We hold to the principle that everyone with supports is capable of self-direction, and certainly every person is unique and knows best what works for them. So then, what are the basics of this model? And we're assuming that many of you have experience with self-direction, you know, in other areas. For instance, working with the elderly, working with people with physical or developmental or intellectual disabilities. So the basic elements are different, are the same, but there are some elements that are really augmented, we feel, in this whole area of self-direction and mental health. But in every case, it's starting with person-centered planning, based on the person's strengths, capabilities, preferences, goals, creatively and flexibly. And as we're all learning, getting across this idea of person-centered planning is sometimes easier said than done, and it's well worth all the effort that goes into it. The elements then in a self-direction with a, as it's enunciated in these programs, is then the person has an individual budget. And whereas the amounts of this budget and the methods by which it is set can vary and do vary across our states, it's essentially a budget using some of the money that often was spent on other more traditional services and allowing the person significant creativity in what are their life goals and how do they reach them. Are they involving employment, education, personal life changes, often used for non-traditional goods and services as well as for traditional services. It's clear in self-direction across models that supports are useful and play a critical part even in their own right. We've emphasized here the brokerage support, which I know goes under different names in different places, but it's, the type of help working with the person to develop their plan, to find those resources, to manage the budget, to develop backup plans, to think about any training needs. It is quite different from, the more medical model of case management. It's a real coaching function. And in this whole area of mental health, it's very clear in our experience that peers, people with lived experience, can play a really vital role as support brokers. When we talk about the essential elements, we often also, at least in the United States, have an additional support, which is the financial management service that helps, at no cost to the participant to manage the budget parts, keep the reporting, and there certainly has to always be a quality management function that's, carefully thought through. We've had next to no, very few experiences with fraud and abuse, but a lot of this is because of the attention that goes to quality management. So the next slide, this is more an overview in the United States of who is self-directing. We, at the National Resource Center for Participant-Directed Services, every 3 years we have been doing an inventory across our country, and we've just passed the point of where we have close to 1.1 million people in the United States who are self-directing, either in an employer authority where they can hire and fire the worker of their choice, or in this full budget authority where they get, major control over the budget as long as it meets the litmus test of tying back to recovery goals, to being independent in the country, in the community. So we have, of that 1.1 million, about 1,000 in the area of mental health services. And we've listed on the slide the types of people who have in the United States the opportunity to self-direct a budget. The only thing that I'd say before leaving this slide is, whereas our experience in the United States with self-direction and a budget control model dates back to what we've called the cash and counseling demonstration, which is really now 20 years ago, but it involved 6,700 people, true random assignment where half of those people stayed in the traditional system, half got to manage themselves. And our results were so beyond our expectation, both in people's satisfaction with distinct elements of their care, their reductions in unmet need, even affecting health conditions. We later, with funding from our Federal Substance Abuse Mental Health Services Administration, were able to go back, and we found that over 20% of all the people in the original cash and counseling demonstration had mental health diagnoses and expenditures on their Medicaid billings claims. And we looked at the experience of those people with the mental health, diagnoses and found how much better they did also than the people in the comparison group. And that's a good part of what set us on the last 10 years where we've concentrated on, self-direction and mental health. So I think I'll say one more thing before we stop, for questions to talk about the model. But leading up to the International Institute for Mental Health Leadership meetings in 2015, the ones that were held in Vancouver in your country, we had the privilege of hosting an international learning exchange. We had people from 7 countries and, around 45 people. And really the 3 things that came out of that meeting that we've been working on ever since. The first is that self-direction represents a culture shift. It isn't just a program. In fact, it's at its base a value-based systems change. Clearly, people with lived experience are not only involved, they're involved at every level and supported. And thirdly, there was a strong feeling that communication is essential, especially if policymakers are to both understand and then see that this model has potential for people with serious mental illness. The group felt that what was needed was a communication strategy that included both the stories of diverse groups of people, who had used these budgets to change their lives, as well as a look at the research to date that shows the potential of this model. So the brochure that we have shared with all of you, and we've recently shared with state policymakers across the United States, is really what grew out of, those pre-sessions for the international meetings in Vancouver. So those we'll refer to again before the session's over, but maybe this is a good time to stop and make sure we're all on board as far as the essence of the model and approach.
Well, actually, Kevin, if it's okay, I just had a couple other slides to add a bit more background, and then we'll do the questions, if that works for folks. So hi, everyone. This is Bevan Croft, and I have just a couple more pieces to add to what Kevin said, and then as we said, we'll stop just to make sure, this model may be very new to many of you, so we want to make sure people are on the same page about, what we're talking about when we talk about self-direction before we go further into our research and our work. But just taking a bit of a step back and looking at the movement in the United States toward self-direction in mental health, we can trace the progression here in the States all the way back to the consumer survivor movement, you know, in the 60s, 70s, 80s, and continuing to thrive today, that really has advocated at a grassroots level for increased choice and voice for people who use mental health services, and also to the advent of peer-delivered services, which Kevin has said a couple times are integral to self-direction here in the States. In 1999, our Supreme Court ruled in the Olmstead decision that states must provide care in the least restrictive environment. So if a person is institutionalized, receiving services in an institution, and their needs can be met in the community, then states have a mandate to move that person into the community and meet their needs. And that really marked a shift in the American disability support and mental health systems to focus more on community integration. And states have been slowly but surely progressing ever since in that direction. In the early 2000s, we had a landmark report called the Report of the President's New Freedom Commission in 2003, and that was the first report to really name self-direction as a concept, and that report also outlined, again, more of these principles about person-centeredness, consumer family-driven services. And the Substance Abuse and Mental Health Services Administration, the division of our Department of Health and Human Services that focuses on mental health and substance use issues, also named self-direction as part of a good and modern behavioral health system in a landmark report that came out of that agency in 2011. In terms of U.S. health reform, the Affordable Care Act, otherwise known as Obamacare, included some key changes to our Medicaid program that actually allowed mental health self-direction, allowed states to adopt mental health self-direction. It sort of removed some regulatory barriers to adopting self-direction for mental health. No states have taken Medicaid up on this new option yet, notably, but it's there. And also the Institute of Medicine report, or the Institute of Medicine there's been a lot of reports coming out of the Institute of Medicine on the physical health side, focusing on person-centeredness. So we can see a move toward person-centeredness in all areas of healthcare, not just in mental health care. Currently, as you may have noticed, our political situation has shifted since the days of Obamacare, and we are in the midst of potential additional changes in health reform, and everything is rather uncertain. But we do know that self-direction as a concept historically in the United States has had bipartisan appeal. Republicans and Democrats have been in support of self-direction. The emphasis on personal responsibility and state innovation appeals to conservatives, while the emphasis on empowerment and innovative practices to support people living in the community appeals to folks on the left as well. So we'll see where it goes, but it will be interesting to watch. And just one more slide, just to operationalize this a bit more before we go into questions, and I see a couple coming in already, which is great. These are the 6 states that are participating in our demonstration evaluation to varying degrees. The first is Florida Self-Directed Care, and this is the largest and longest standing effort in the country. It was established in that state's legislature in the early 2000s and has been running ever since. In the state of Michigan, that state is unique because through their Medicaid managed care waiver, anyone is receiving publicly funded mental health services may elect to self-direct, although the take-up has been relatively low. And in that state, certified peer specialists work in that support broker function that Kevin mentioned. The state of Utah is unique in that it converted an access to recovery program, which is a voucher-based program for people with substance use problems. They sort of adapted that for people with primary mental health issues and have been looking at how that works. In Pennsylvania and Texas, there are a couple of different initiatives going on in partnership with managed care companies. Pennsylvania's is ongoing, and Texas has had a couple of different trials and expects to start enrolling participants in a new effort in 2017, and we'll be collaborating with them, with the evaluators in that state. And finally, in New York, I mentioned the 1959 state plan option in the last slide. New York is the state that's the closest to implementing self-direction through an option like the 1959. They're using a slightly different authority, which is the Medicaid 1115 research and demonstration waiver, but they're anticipating to begin enrolling participants soon, this summer, and that will be, once it's up and running, probably the largest demonstration to date, so we'll be watching them closely. All right, so let's pause for some questions, and if you could, we're hoping to use this brief question and answer period for just kind of logistical questions about the mechanics of the model, how it looks in the United States, and then if you have more substantive questions about dynamics or other types of discussion questions, we'd love to hold those until the end of our presentation so that we can make sure we've given you all of our information before we delve into that kind of discussion.
That's great. Thanks very much, Bevan and Kevin, for giving us sort of some highlights about the model. So again, we just encourage people, again, using the chat function, and if it's not up on your screen, it's on the top right-hand corner. You can click on that chat conversation bubble, and then if you want to send your questions using all panelists as the drop-down, we can ask those on your behalf as your phone lines are muted. So maybe just as we're getting started, we do have a couple of questions that have come in around the funding and how the funding works and where the funding comes from and whether it's a redirection of funds from other programs. So maybe we can start with that question first.
Do you want to start, Bevan, or should I?
Sure. So the short answer is that the funding is different in every state, but there are a couple of different rough models. So one, we could think of as sort of the most integrated model is where the person who's self-directing works with their broker to look at the previous year's expenditures for mental health care. And then sets a budget for the coming year, maybe based on those previous expenditures, need, planning, some other method, and has a set budget that would be their mental health services budget that includes all of their treatment services, case management, outpatient. In all models, emergency services and prescription medications would not be included in that, so you carve those out, and then a person would work with that budget and adjust as they see fit. They may use, say less clubhouse and case management and more therapy, or go from seeing a psychiatrist once a month to once a quarter, and then use some of those funds to work towards, some other goal, say an employment goal. So there are, really a range of ways and dynamics, but essentially it would be moving around the money that would have been spent on their publicly funded mental health treatment. So that would be an integrated model. Another model, which is more like what's used in Florida, is that a person may have, say Medicaid insurance, and then they receive on top of that Medicaid benefit some additional pot of money, say $1,800 a year, something like that, to use those funds flexibly to either augment the services that they're receiving in Medicaid or to buy non-traditional goods or services like transportation, bus passes, things like that. So there are a few different models.
Let me add just at maybe a higher level. Each of our states is different. In that sense, we're coming to understand it's not unlike your provinces. So that one of the things you'll see that Bevan is doing in our process evaluation, is laying out the approach each state used. One of the things I'd commend to your attention is on the last page of the brochure we shared. We wanted to share the names and contact information on the program leads in each of our states, so that if you really wanted to talk to them even in more detail after this, you'd be able to do so. You know, in general, we know that some states it's an add-on, some states try and redirect some of the money that's spent on more traditional services. You'll see in Bevan's later presentation that there's good evidence that people with a budget use less traditional services. On the other hand, if the budget's an add-on, it's harder to be cost-effective just within the health realm, but you'll see some of the effects she's found on housing stability and employment. When it gets to how the support brokers are paid, again, it varies by state, but most often it is not, it's an administrative expense, not, you know, borne from the budget.
That's very helpful, thank you. And we've had a couple questions as well around the brokerage support, and I guess two specific questions. One is who pays for that service? Is that something that the funds are, like from the fund that they have in place, do people use that to pay for the brokerage support, or is that provided as an addition? And the second question is really around the role that those brokers play, and do they coach around and do sort of person-centered planning, or are they also assisting people with managing the fund that they have available?
Yeah, so again, varies from state to state. I would say in most cases no, I won't say that. So the support broker is engaged in the person-centered planning process. In some states, the support broker is really the key contact with the person on the person-centered planning process, and in other states, the case manager and the support broker may work in collaboration with the participant on the person-centered planning process. But the support broker is always involved in person-centered planning in an integral way. And was the other question around financing, how the support broker service is financed?
Yes, and who pays for the services of the support broker?
Yeah, so as Kevin mentioned earlier, in some states that's an expense on, that's funded through the mental health authority, either through Medicaid, if it's Medicaid billable. For example, in most states, peer support is a Medicaid billable service, or depending on the budget, it may come out of that person's budget as part of that self-directed budget. So again, varies, but there are different options and models for that.
That's great. We have one last clarification question around, Bevan, when you showed the slide that looked at what those 6 or 7 states were doing with respect to self-direction, in all of those states, is that specific to mental health, or is it broader than mental health?
Yeah, these are specific to mental health. So these 6 states are, for all 6 of these states, one of the eligibility criteria is that a person have a diagnosis or a designation as, of a serious mental health condition.
Great.
And on a broader level, every single one of our states has at least one budget authority program for some disability population.
Yeah, so
that's interesting to know, yeah.
Yeah, so I mean, if you just kind of look, and this is why, as Kevin mentioned, so there's over 1 million people self-directing in the United States, but the vast majority of those people fall into these populations self-directing. So older people with long-term care needs, people with physical disabilities, a lot of people with intellectual developmental disabilities. So only, 700 to 1,000 people with serious mental health conditions in these 6 states are self-directing. I'm sure that many of the people self-directing of that 1.1 million, have a mental health condition, but it's not they're not enrolled in a mental health self-direction effort.
Okay, that's very helpful. So I hope that we've covered all the questions that people had about the model and the approach itself. If you do have additional questions, certainly feel free to send them in through the chat function during the remainder of the presentation. As I mentioned, we'll have some time for some more fulsome discussion at the end of the session, but I'll maybe turn it back over to you for the rest of the presentation.
Great, and I just did see, I was just looking at a couple of the other questions. A lot of these questions are going to be either answered in the coming slides or we'll revisit them in the discussion, but I did see a couple of questions just around complementary medicine, alternative medicine, naturopathic services, massage, acupuncture, et cetera. The short answer is that yes, participants can and do use funds for those types of services. So next we're going to talk about the demonstration and evaluation that we've alluded to. And one thing to say just before, Kevin, I'll hand it over to you for the next couple of slides, is Kevin's mentioned the brochure a couple of times. I believe you've been sent a link to that PDF of the brochure, and if you haven't, you'll get one shortly after the webinar, but this was really created as part of the demonstration and evaluation effort and designed to showcase, what the model is, what the existing research evidence is, alongside, importantly, personal stories. So we worked with a communications firm who went to Pennsylvania and Florida and interviewed and videoed participants to talk about their experience. Those videos will also be up on a website coming soon. It's not live yet, but it will be mentalhealthselfdirection.org. Julie was one of the participants who was interviewed for that project and actually came out to a conference in May to share her story as well, and it was quite powerful. So over to you, Kevin.
Okay, that's a nice transition, thank you. Yes, Julie, that you just saw, the conference we had in Baltimore the beginning of May, I think we had over 350 people. And after Julie spoke, I think we could have all gone home. Her presentation was so good and so powerful. And then she stayed on as we worked with our 6 states, the next day on, a lot of the implementation issues we're facing. But I'll talk very quickly through this. This is more our United States experience, but our demonstration started with our technical assistance awards to these 6 states. And these awards, you'll see what a partnership our whole effort is between private foundations, our federal government, and various states and participants. But it started with the Substance Abuse and Mental Health Services Administration making awards to the states you saw. They've made a couple of rounds of technical assistance awards, and the states committed right from the beginning to work at least once monthly on a learning exchange, and we have listservs for sharing information in between that. But it starts with the learning exchange and the technical assistance opportunities funded through our Substance Abuse Mental Health Services Administration, and they use our National Association of State Mental Health Program Directors to, as a conduit for the funding. The next slide is is a bit busy, but I'll make it easy. At the top, what you really see are the funders. And in these difficult financial times, we've been able to really work between the Robert Wood Johnson Foundation, that's the RWJF, and our Federal Substance Abuse Mental Health Service Agency as a real partner. And in some states, for instance, in New York, there is a local funder. The New York State Health Foundation is part of this. So it's a real partnership between private funding and federal government. On the left side of this graphic, what it really amounts to is that's the side that emphasizes the technical assistance and learning exchange between the states. On the far right, every state has its own particular level of evaluation they're doing. But at the core, and this is the vertical line down the center, the heart of what we're doing, we at the National Resource Center coordinate this effort, but the real heart of this is what Devin is leading at HSRI, and HSRI is our Human Services Research Institute, where you'll hear for the rest of this presentation the type of work they're doing on a process evaluation, capturing the experience and lessons of each state, as well as an outcome level evaluation focused on the system level. And Bevan, I turn it to you.
Great, thanks, Kevin. So this evaluation really has three main components. The first is a formative process evaluation because, as you may have gathered, self-direction is a nascent model in mental health in the United States and really worldwide. And there's a lot we don't know. We don't have established fidelity criteria, and really we're working at this stage on just operationalizing these core elements. We know that person-centered planning is a component. We know that support brokerage is important. We know that we're talking about a budget, but within those large buckets, there's a ton of variation. So through the process evaluation, we're really seeking to document these implementation activities and begin to work toward guidelines for best practice, maybe fidelity, to really support additional states to replicate these efforts, and the states that are implementing self-direction to expand those efforts beyond, just a few hundred people. On the outcomes level, we're looking at the systems level and the individual level. At the systems level, we're looking at the cost and service utilization implications of self-direction using available data. So in many cases, this means administrative data in sites. And then at the individual level, it looks different in each state depending on the unique relationship with evaluators, whether or not there is a formal evaluation, but ultimately we're looking at key outcomes. And outcomes that are important when you're talking about self-direction are health and well-being, and then recovery in its many domains. So quality of life, and then drilling down, things like employment, stable and independent housing, community inclusion, social connection, self-esteem, self-efficacy, things like this. And I'll be speaking a bit more about some of our findings as we move through. In the process evaluation, I'm not going to talk a lot about the process evaluation today. I think it's probably a topic for another webinar, but just through the slide in, just to show that we are using the RE-AIM framework, which is a commonly used framework for evaluating public health interventions, and we're looking at these different elements. So R stands for REACH, which is self-direction being offered and available to people who might benefit from it? And as we said earlier, one key premise of self-direction holds that everyone is capable of self-direction given adequate support. So how is that working out in the states? What is the representativeness of the people who are self-directing relative to the general population of people with serious mental health conditions receiving publicly funded mental health services? Efficacy is really looking at impact on outcomes. Adoption is understanding whether and how states or communities within states, many of our states have county-based systems, how they adopt self-direction. So what are the stakeholders' roles in either driving or hindering self-direction? What stakeholder groups promote it? What stakeholder groups may not be promoting it? In terms of implementation, this is really charting those implementation elements, design of programs, and finally maintenance, sustainability. How is this being financed? Is it financed in a way that's financially sustainable? Is it staffed in a way that there's institutional memory of self-direction that carries on when people leave, things like that. So going to the current evidence base, this first slide just reviews some research that has been done previously to our work. Up through 2014, you can read about the existing research of self-direction in a systematic review that was done by a group in the UK and looked at 15 studies that have been conducted through 2013. I believe 4 of them were in the US. There's been a good amount of research in England as well. And those studies have had significant methodological limitations, so no comparison group or inadequate comparison conditions, small n's, things like that. But with some confidence, the authors of the systematic review found that mental health self-direction was associated with choice and control and increased quality of life. In England, the National Health Service rolled out a personal health budget pilot that included 412 people who were in the mental health group. And that study used a quasi-experimental design and looked across different sites and documented greater care-related quality of life and psychological well-being, as well as reductions in costs, both inpatient and outpatient, for the mental health group. And actually, those reductions were most marked in the mental health group compared with other disability groups. Another important finding from that study was that the sites that offered more choice and flexibility also saw greater improvements in outcomes. Finally, in 2016, there was a paper published in Psychiatric Services that looked at the types of goods and services that were purchased by people in Pennsylvania. And that study wove in the concept of personal medicine, which was developed by Pat Deegan, a researcher here in the States, that really shows that in mental health, people use a variety of strategies to meet their goals and to be well. And those strategies may include clinical interventions like meds, but they also include a whole host of other personal strategies, you know, from meditation to exercise to diet, nutrition, and on to meet their goals and be well. So self-direction really sort of confirms that theory. I'll talk a little more about that as well. In terms of the findings that I'm going to present for the remainder of this presentation, we have a qualitative paper that has been published in the Community Mental Health Journal where we explored the relationship between self-direction and recovery at the person level and describe those experiences. We also have a paper that is under review, under peer review currently, that looks at the relationship between self-direction and 3 key outcomes: employment, independent housing, and support group engagement. I'll talk a bit about that. And then on the quantitative exploration of system-level factors, we have looked at how Florida self-directed care participants spend their budget and are working on a paper looking at the impact of self-direction on mental health service use and costs. And those results are not quite ready for prime time, but will be coming soon. For our qualitative paper, we conducted semi-structured interviews with 30 Florida SDC participants who were purposefully sampled along the lines of gender, insurance status, program site. There are 2 Florida self-directed care programs in the state, one in the southwest area of the state and one in the Jacksonville area of Florida. We transcribed the interviews and did a basic qualitative content analysis where we came in with an a priori recovery framework and then adjusted that framework, accounting for emergent themes and phenomena and relationships between themes as we did the analysis. So the final framework that we landed on was this one here. And really what this shows is that people worked on a whole range of recovery domains, and those are in that middle column there. But that before folks were seeing gains in the recovery domains, many participants described a need to use their self-directed budget to meet basic needs. So things like maintaining housing, furnishing houses, so buying mattresses or basic furniture. Dental care was very important to people, and participants that we spoke to really described a need to, at the beginning, to use their budget to sort of clear the way and address major barriers to their wellness and recovery, sort of material needs related barriers. And then once those were addressed, participants reported gains in a number of domains. In the clinical domain, people talked about expanding their treatment. So rather than going to the public mental health clinic where there was only one psychiatrist and the wait times were took forever, people went outside network and used their budget to cover additional co-payments or additional fees associated with finding their own psychiatrist or another clinician that might not have been available to them through the publicly funded system who could address specific needs related to their unique needs. So clinicians specializing in trauma, for example, or in domestic violence or different things. In the functional recovery domain, a good number of participants were either volunteering, seeking paid work. 3 of the people that we spoke with were engaging in a sort of a micro-enterprise type effort, starting their own business and using self-directed funds to do that. And people were also searching for and maintaining independent housing, using their funds for, say, a down payment or a first month's payment, moving expenses to move, out of an undesirable housing situation and into a more independent housing situation. Physical wellness was very important for a lot of participants. There were a lot of people who used their budgets for gym memberships, wellness coaching, those sorts of things. 10 of the 30 people that we interviewed identified as being in substance use recovery and described self-direction as a way to support their ongoing efforts to be engaged in the recovery community and stay sober. And then a lot of participants talked about group membership and getting engaged in, like mental health support groups, advocacy type groups, but also just community groups, bowling leagues, church groups, quilting guilds, different things like that. And the final column on the right, existential recovery, which was part of our original framework, we moved to the side and put bidirectional arrows between this and all the other recovery domains because people really said that that meeting goals in these other domains of recovery gave them self-esteem and greater self-confidence to set and reach additional goals. So there seemed to be sort of a circular benefit to participating in self-direction, meeting goals, getting more self-confidence in one's ability to meet those goals, and then reaching further. So those are the qualitative findings. For our quantitative approach, in Florida, we used administrative data. So we received a very large data set containing demographics, mental health outcomes information, and service utilization data for everyone who was eligible for self-directed care. So that includes people who had a serious and persistent mental illness designation by the Florida Department of Children and Families, which is the entity that oversees mental health services in the state, over 18, lived in the program service area. So it was a very large, potential comparison group. We then used a method called coarsened exact matching, which is similar to propensity score matching, but more straightforward, to construct a stratum for each observed set of covariates, and those are listed here. And we matched individuals according to those strata. So for each Florida self-directed care participant with the following set of characteristics, gender, ethnicity, race, completion of high school, marital status, diagnosis, et cetera, was matched to a non-participant with that exact same set of one or more, non-participants with that same set of characteristics. So this table shows the numbers pre and post match, So in total, we were working with 403 data from, before matching, we had data from 403 self-directed care participants and over 12,000 non-participants. And then once we matched self-directed care participants to non-participants, we were left with 364 self-directed care participants and 2,659 non-participants. Oh, excuse me. We used logistic regression then for 3 individual level outcomes that I will describe here. So we looked at changes from first assessment. Oh, and I forgot to mention the study period was about just a little over 4 years. It was different in each site, but we had roughly 4 years of data. And we compared a person's outcome at the first assessment to the outcome at last assessment and constructed variables denoting a positive outcome in 3 areas. So the first area was employment, and we considered a positive outcome to be if the person either increased the days that they worked for pay in the past 30 days, or if they were already working 20 or more days for pay, they maintained that from first to last assessment. So we were looking for increased number of days worked for pay in the past 30 days, or maintaining, like a full-time days worked for pay. And days worked for pay includes formal employment as well as informal employment, so it was a fairly responsive measure to the concept of employment. In the housing domain, we considered a positive outcome if the person attained an independent residential housing status, so they went from being homeless or living in a group treatment type setting to living independently from first to last assessment, or if they were living independently at first assessment, they continued to be living independently at the last assessment. And finally, we looked at support group engagement, and in these data, support group referred pretty loosely to any sort of group, unpaid sort of self-help group that a person might be engaged in. So that could be something like Alcoholics Anonymous if a person is in substance use recovery, or a mental health support group like in the U.S. we have the National Alliance on Mental Illness support groups, or Depression and Bipolar Support Alliance, something like that. It also included sort of mental health advocacy type groups. So we considered a support group engagement measure a positive outcome if a person increased engagement in support groups from first to last assessment, or if they were already engaging at first assessment, if they continue to engage at the same rate. And the findings from the odds ratios from our logistic regressions are presented here. So these are odds ratios using a logistic regression method predicting a positive outcome related to self-directed care enrollment, controlling for a host of observed factors. So the ones that I listed before, things like age, diagnosis, race, ethnicity, marital status, high school completion, as well as other factors that we were able to measure and pick up in the administrative data in this analysis, things like having been assessed as having limitations associated with activities of daily living, having been institutionalized during the study period, having been arrested during the study period, a number of covariates. So each of these odds ratios were statistically significant, meaning they were not arrived at, we can say with some confidence that they would not have been observed by chance. And we found that compared with people with similar characteristics who weren't self-directing, Florida self-directed care participants were almost twice as likely to experience a positive employment outcome, almost 3 times as likely to experience a positive housing outcome, and 2.72 times more likely to increase or continue their engagement in support groups. Finally, I mentioned the cost and service utilization. One thing that we did as a first step was in one of the program sites for Florida Self-Directed Care with 173 participants, we broke down the purchase types. This type of data was only available in one of the sites. And this graphic depicts what proportion of total spending across all purchases was made in a number of areas. So the most commonly purchased area, and also the area that accounted for the highest proportion of total spending, was transportation. So bus passes were very common, bicycles, some car repairs, people using their funds to make sure that they could get around. And then the next highest proportion of spending was dental care. As I mentioned before, meeting basic needs was very important for a lot of participants, and dental care was at the top of the list for many people. Medical services refers to psychiatry primarily, medication management type services. So these are people who may have used their budget to go out of network and see a different kind of psychiatrist, or in the Florida Self-Directed Care Program, people who are not on health insurance are given a larger budget and can use those funds to directly purchase mental health services. So that would be what much of this 9% is accounted for. And then on down the list, you can see a wide variety of services and goods. Computers, employment-related support, so things like clothing for job interviews or work tools, support for setting up a business, things like that. Vision care is there, things like hobbies and entertainment, and so on. So really a broad range of strategies for recovery. I need to touch on some key limitations of the data that I presented to you. One is there are a number of problems using administrative data that are collected really for the purposes of billing and reporting, and not for the primary purposes of research. So, you know, could we do this again? If we were looking to replicate the findings, we would want to be using things like survey data, where we're really looking at, and capturing all the variables that we know are important, because really using the administrative data, we could only look at the data that were available to us. These findings are from just one state in the country, in just one area with one population, and this is an incredibly diverse country with incredibly diverse mental health and substance use treatment systems. So there's some limitations associated with generalizing these findings to other states and other systems, and certainly to other countries. We did find, I didn't talk about this a lot with the findings, but we did find in Florida that there was difference between the two sites in many ways, which really leads us to conclude, and we know this from other work as well, that implementation and program design have such critical implications, both for person-level outcomes, but also for system-level outcomes. How we think about cost, what the bottom line is for cost, things like how support brokerage is covered and paid for, what types of services people were using prior to self-direction, things like that. And then the other key policy implication from both of these papers, especially from the qualitative work, is that people receiving publicly funded mental health services are far more likely to be living in poverty, and they also are likely to be experiencing barriers to access even before they self-direct. So those are critical contextual factors in understanding self-direction, because people are not just blank slates when they begin to self-direct. They come with their own histories and their own needs, and many of those needs are related to poverty and a lack of access, in addition to any issues related to, their mental health diagnosis. So just a few key takeaways before we close and move to questions, and I see there have been lots of questions coming in. One key takeaway is that in self-direction mental health, we see when we hand over the control of a budget to individuals, we see wide variation in the types of things that people purchase. So they do purchase some clinical services, but they also look to goods and services that we definitely wouldn't traditionally consider mental health treatment. With our study, we have so far established a positive relationship between self-direction and recovery and circular gains in independent self-esteem and self-confidence. So that's that recovery framework from the qualitative paper that I reviewed earlier. We found in Florida in one study that people who are self-directing were more likely than non-self-directing participants to see positive outcomes related to employment, housing, and support group or self-help engagement. And that's those findings should really sought to be replicated in the future with stronger designs and different samples. And that's it. If you have further questions, I would be happy to talk after this presentation. Also, please do be on the lookout for the brochure, and once it goes live, our website may be a resource for you if you're interested in learning more. It will be www.mentalhealthselfdirection.org, and it is not yet live, but hopefully will be very soon. So happy to open up to questions now.
That's great. Thanks very much, Bevan. And we did send folks a link to the brochure both in the invitation for the webinar as well as in the chat area, but we'll recirculate that again for people that are looking for that reference. So we do have quite a few questions that have come in. Some of them I think you've answered, Bevan, in the last half of the presentation, but we'll maybe circle back to a couple for some additional comments. With respect to some of the outcomes that you found through the study, has there been any research on any potential cost savings of this type of model?
Yeah, so that's one of the million-dollar questions, no pun intended. So a couple things I can say. One is that in England, there were observed reductions in cost for people who are self-directing compared to people who are not self-directing. In Florida, we found in our preliminary analyses that are very preliminary, we have observed similar reductions in outpatient costs, service utilization. But how the program is financed and structured really depends on whether you would consider those cost savings or not. And the other thing that's important to think about when you're talking about cost with self-direction is that this is an intervention that potentially impacts so many domains of life that there may be cost savings to other systems than healthcare utilization or mental health care utilization. So savings to housing support systems, social welfare systems, criminal justice systems, other things, and in sort of a straightforward cost analysis using administrative data, there's no way to capture that savings, at least not in the United States. So it's really important to think about that, think about cost in a nuanced way. So no straightforward answers. We hope to move a little, to paint a little more of a picture when it comes to cost as we continue our research in the next few years. But the answer to the question is there's promise, but cost savings really depends on a lot of implementation factors that we're still getting a handle on.
I'd like to add to that, or just build on what Evan said. You know, you can see from the way people use their budgets, this is a life-changing, a recovery approach. You can see the types of things they spend money on. So in a sense, we just met with all of our states and we were talking about this issue. People often want us to find savings just within the healthcare financing domain. And in a sense, the outcomes we're looking at are broader than that, so shouldn't the cost effectiveness measures be the same? Our understanding is that in Australia, you know, in the modeling that was done by KPMG for, you know, their national disability insurance scheme, it looked at, you know, what are the effects on employment, on taxes, on reductions in prison usage, et cetera. And we're trying to move the needle to pay attention broadly to these types of outcomes.
Great, thanks, Kevin. We do have quite a few questions that have come in. If you do have additional questions you'd like to ask, feel free to type them into the chat window, but It was great that Bevan provided her email address as well, so if we don't get to all of your questions, certainly feel free to follow up with her directly. We'll try to get to those that have been asked by multiple people. So quite a few people have written in with questions about the eligibility criteria, and I'm wondering whether that's something that you can speak to. Are there specific requirements specifically for people with mental health issues and sort of criteria that they need to meet to be eligible for this type of program?
Yeah, and I haven't looked through all of these questions as they've come in, but one thing I'll say is that the eligibility criteria are fairly broad. Again, working from the premise that anybody has the capacity to self-direct given adequate services and support. So I think I might have seen some questions coming in around, like, does a person need to be taking medications in order to self-direct? The answer to that question is no. There's no formal requirement that people be taking medications to self-direct. Really, the criteria are that a person typically, I think in all of the sites now, being adults, that they have a diagnosis or of a significant mental health challenge, operationalized in different ways, or have a psychiatric disability, so be receiving disability income for a mental health condition. In some states, I believe there's some limitations related to whether a person has a legal guardian or not, but not in all. In some states, if a person has a legal guardian, they are welcome to self-direct, but obviously the guardian would be involved. I don't know, Kevin, anything to add about eligibility criteria?
Well, I was just looking at some of the questions. In the United States, so many of our programs, our public programs, are focused on the poor and near poor. Certainly that tends to be true across all of the states we've mentioned, and all of them basically are paying attention to the serious mental illness definition that our Substance Abuse Mental Health Services Administration uses.
Yeah. Yeah, and you know, just one other thing to say about this is I mentioned our process evaluation looks at the RE-AIM framework, and the R is REACH, and I think it's very important. There are formal eligibility criteria and informal eligibility criteria, so just a couple quick points about that. It hasn't been formally documented, but I think that there and the Weber literature review that I mentioned earlier notes that there's some concern or have been criticisms in the past of some self-direction efforts that, you know, only people who are deemed quote-unquote capable or ready to self-direct may be invited to participate. And so that would be like an informal eligibility criteria, right, that we might be concerned about. So there may be dynamics like that happening in some places. In other states, like Michigan, for example, the case managers there who do the recruitment for self-direction in one area were asked to think about the people they work with who are least well served by the system, for whom you know, nothing seems to be working, nothing seems to be helping them in their recoveries, and to encourage those people to self-direct. And they've actually had some real success turning things around for some people with some very complex lives and very complicated needs. So just a couple of anecdotes to get you thinking about eligibility and reach.
To even add to the, you know, our state-specific nature, state like Utah, a good amount of the funding they're getting is from their corrections, from their prison system, you know, so focused a lot on people in discharge. They also get funding from what we call TANF, but it's focusing on long-term unemployed. You know, so in each state there are specific criteria that go beyond what we've listed.
Okay, that's really helpful information, because certainly we had a number of other questions around whether self-direction is targeted to specific groups, whether that's either economic groups like people that might be living in poverty or people that are homeless or people that maybe have not responded to other types of treatment and therefore are not on a path towards recovery. But I think maybe you've answered that with some of your comments to date. Another question that we had is whether or not there's any learning on specific subsets of the population for whom self-direction does not work, whether there's any analysis that you've done on that front.
We are not at a point where we've done analysis looking at particular populations and looking at differential impacts or things like that, but the research is probably not there yet. One piece I can offer theoretically is that a construct of something like activation, motivation for change has been hypothesized to be a key factor in self-direction. So people who are more activated are more likely to opt to self-direct and more likely to do well self-directing once they've self-directed. But again, that's a hypothesis. It's being tested now in a couple of our sites that are collecting patient activation information, but we don't have findings yet.
And what I'd add, having glanced at another of the questions that came in, clearly our work in this mental health area is seminal. It's developing. These are where our government officials wanted to see larger system-level effects, and that's a good part of what we're focusing on. We've had a couple of modest controlled experiments with hundreds of people. So we're learning in the mental health area. On the self-direction in general, one of the questions was asking, what's the possible reach? And Bevan and I were just talking about that earlier this week. You have in our country a state like California, where in their in-home supportive services program, which is personal care for the elderly, people with more physical disabilities, 85% of them are self-directing. The issue has to do with what's the culture, the service culture, what are the supports to people. If people are struggling, what additional help is available. The other thing is we were involved in the developmental disabilities, the intellectual disabilities, and finding even the 6 states we looked at, the penetration range from 2.5% to well over 20% self-directing, and they were clear hypotheses of what were the states doing that were making it possible for more people to have that opportunity. What we find as we go forward in mental health, that's a wonderful part of what we're hoping to see.
Wonderful. A few people have written in with various questions around sort of any concerns around this approach or sort of barriers to implementing this type of approach, and whether it's with either clinicians or healthcare providers sort of not being on side, whether it's about people sort of burning through their funds too quickly and not having enough funding that's left. How it might impact on sort of wait lists for mental health services. So not to sort of direct your questions there, but I'm just wondering if you could comment a little bit on what some of your experience has been around any barriers to implementing this type of model.
Sure. There are barriers on many levels. One barrier, I think early on, in our work that came up again and again was that self-direction is giving the power of the purse to service users. in a way that they maybe haven't had before. So people can really vote with their feet, and if they don't, like working with a provider, they can leave and go to a different provider or do something else entirely. And in that way, for some providers, self-direction might be viewed as like a threat to their sustainability because it could mean, I guess, say, losing business. But when we've talked to providers who are knowledgeable about the model and definitely to providers who work with people who are self-directing, we haven't really found that to be the case. And more often than not, providers who see people self-directing and doing well are really excited about it because they're in the field not to see as many people as possible, but to help people do well. So unclear to what extent that's really a barrier, particularly when providers are educated and informed about the model. Another barrier that's been identified is just around administrative complexity, and this being something new and somewhat complicated and different than what our mental health systems are used to doing. So just administratively, it can seem complex. There's an investment in time and infrastructure to set up the system where people are able to manage and control funds. If people have employer authority, setting up payroll and figuring out the tax issues and workman's comp, all those sorts of things. So there are some administrative barriers. Another system-level barrier that's been identified by a lot of administrators that we've spoken with is just, the American healthcare system is in such a state of change right now. We're integrating mental health and substance use. We're integrating physical and behavioral health. We're expanding Medicaid. We're not expanding Medicaid. There's a new administration now. Everything is up in the air. So there's a sense of overwhelm at the leadership level that makes it hard for some people to even think about self-direction, which really represents a pretty significant paradigm shift on top of everything else. On the other hand, some leaders that we've spoken with really see this as a good time to try something new because everything's in flux, there's opportunity and chaos. In regard to the question around, what if a person spends all their budget, blows all their budget in their budget for the year in the first month or something like that? There are a number of program design safeguards that can and are put in place so that doesn't happen. People work with a budget on a quarterly or a monthly basis rather than, getting the budget for the whole year. That's one thing. The other thing is that the person-centered planning process is integral, so no purchases are made that aren't connected to an objective and a goal in the person-centered plan, so you can't just decide to spend all of your money willy-nilly on something that you want. It needs to be a planned process with steps and a timeline that's done in collaboration with a support broker and maybe other members of the team. So that has not been, there have been sort of just administrative safeguards that can be put in place for that. Another safeguard is taking any emergency services out of the budget. So a person always, in all self-direction efforts in the United States, if a person needs any sort of emergency services, they can receive those whether or not they have money in their budget. Kevin, anything to add about barriers?
Well, in a generic sense, we have 20 years experience, and yes, there were states where there was strong provider resistance. Was it over market share? Was it over quality? And over time, by including people in the planning process, we now have even a speakers bureau of providers in certain states who are willing to talk to providers in other states about how this has worked out, and to everyone's good feeling. A lot of our management and budget worries about self-direction options were handled by our attention to the duties of the financial management service who holds the money, you know, and what kinds of monitoring is done. We work pretty regularly with our Office of Inspector General. But then you get to the area of mental health, and you had a new layer of both issues around stigma, people worrying, can people with serious mental illness do this, which is so much why we wanted to do this brochure showing people's stories and the research. And they also wanted thoughts about the, I'm searching for words, the ups and downs of mental health needs, and how do you adjust budgets, how do you do advance planning, risk planning ahead, and there were various elements particular to mental health that, again, have led people to have more confidence.
That's great. Thank you so much for all those questions. I think we got through most of them. There's a few probably that we didn't get to, but thank you everyone for your engagement in the dialogue. A couple people have asked about whether or not there is any experience with this type of self-directed funding model in Canada. So I think what we'll do is we're going to go away and do a little bit of research on that front, and then hopefully in one of our future webinars we can present on what's been done. I know that there's some experience in using this type of model in home care, but we're going to investigate and see whether in any jurisdictions anyone is using it in the context of mental health and addiction. So stay tuned. So we will be taking a break for our webinar series in July just due to vacation schedule, but we'll be back on Wednesday, August the 30th with our next webinar on employment and recovery. And then in September, we'll have a session offered in French on some of the best practices in suicide prevention that have been done in the province of Quebec. And we're just finalizing the details for our October webinar, but it's likely going to focus on recovery and addiction. So I know that's been a topic that a lot of people have expressed interest in, so we're just finalizing the date and speakers for that session. So just a reminder that after you close the window from today's session, we will ask if you can just take a few moments to fill out a very short survey, provide us with your feedback on today's webinar, and also some suggestions on some content that you'd like to see for future events. That would be great. So thank you everyone for joining us today for this session, and a special thank you to Bevan Croft and Kevin Mahoney for being here and sharing all of the expertise that you have from the United States. That was really great to hear all the fantastic work that you're doing there. And also wanted to say thank you to those behind the scenes here at the Commission that have been helping out, Benita Varga and Laura Mullally, for their help. We certainly appreciate that. So again, if you do have any questions, you're welcome to contact either the staff directly at the Mental Health Commission, or as Bevan has already very generously shared, her email coordinates as well. If we weren't able to answer all of your questions, certainly feel free to reach out to Bevan directly. So again, thank you to our presenters. We appreciate you being here with us this afternoon.
Thank you.
Bye. All right. Bye, everyone. Have a great day.